Thank you, PK, for the kind invitation. Definitely congratulations to you and the team for another amazing Congress. Now, my disclosure. Okay, so vessel prep. In the last years now, vessel prep is part of our life. But if you go to the literature, to the data, there is not a clear definition. So what I did, easy. Nowadays, ChatGPT, asking, please help me to find, the definition for vessel prep. And you see that also the AI is able to say that in PAD, you need some techniques to improve and optimize, the diseased leg before the final therapy. And final therapy is angioplasty with a drug-coated balloon or a drug-eluting stent. This is especially for complex morphology, and this means, long lesion or long CTO, fibrotic lesion, and heavy calcified lesions. So the goal of vessel prep in this challenging setting is to increase the vessel compliance, improve the luminal gain, and improve also the vessel scaffolding, and also to increase the amount of drug that can be uptake into the vessel. On the opposite, we have to reduce the recoil and the possibility of a flow-limiting dissection and obviously of bailout stenting. Now, we know that calcium is the big enemy. This is our study at the beginning that it confirmed that the circumferential distribution is something that we have to manage before the final treatment. And this was confirmed a couple of years later from this ex vivo analysis, where they showed that after debulking, they can increase the uptake of drug. So the concentration of drug into the tissue is much higher if we debulk the lesion. So something that we have to keep in mind when we define, the perfect or the ideal vessel preparation. How we can perform? There are a lot of devices available. We can divide in two big families. We have plaque removal, basically debulking all the atherectomy devices, and then we have the plaque modification. Standard balloon, cutting balloon, scoring balloon, low pressure balloon, special balloons, whatever, and also the IVL plus the flex system. What is important is just to keep in mind that atherectomy is the only way to debulk the lesion, to remove the plaque, especially when there is a lot of calcium. As you see here from IVUS, we have a terrific amount of calcium, and not only the distribution of the circumferential distribution, but have a look also on the thickness of calcium. Definitely, this is a huge barrier for the drug. We never achieve, the drug will never achieve the smooth muscle cells. After debulking, this was done with the oak one, you see we have a beautiful window for the drug to penetrate the vessel, and also the thickness of calcium is less. So keep in mind, that when we perform a vessel preparation, we have to achieve a very nice outcome at the end. This is a nice study, nice paper, because the authors evaluated the damages of the balloon surface of a drug-coated balloon, obviously, when navigate into a vessel where there is not a ideal preparation, so when there is a calcium or some other things. They evaluated 8 different commercially available DCB, 4 centimeter in length, 5 millimeter in diameter, and analyzed the amount of particles, of dark particles lost during the navigation. Each balloon was placed in a system just to stress the balloon surface, balloon inflated, balloon deflated, and then reduce more and more the space, step by step, the space between the balloon surface and some blades. This is just to recreate a situation where maybe calcium could be present inside the vessel. You can see here that for Lutonix and Stellarex, there were no damages on the balloon surface, either if the balloon was inflated or not. On the opposite, for Elutax and also the Impact Admiral, there are some damages with the balloon inflated. Luminor, Ranger, Sequent, they have damages in both conditions. This means that it's not a problem related to the balloon or the technology surrounding the balloon. This means that we need to perform a very good vessel preparation before the use of drug-coated balloon to achieve the ideal final result. This was a single-center study with 97 patients where they stress more this concept of the ideal or perfect vessel preparation. Because you see, they evaluate the vessel preparation, the outcome in terms of luminal gain. If they achieve more than 3 millimeters in diameter, increase in comparison to the reference vessel diameter, the outcome was much better if you compare to just a 1 millimeter increase in diameter. So this tests more this concept that is not just a simple PTA can be ideal, but we have to work more, especially for complex situations when there's a lot of calcium. Just a simple case, a male patient with a lung stenosis in the FEMPOP region. This was treated, with the OAK device, always with a filter, and then, the DCB with a very nice final outcome. I think everyone is familiar with the reality study. It may be one of the most famous ones in the combination of directional atherectomy plus the use of DCB with a 1-year primary patency of 76%. There are also other situations that we can make or we can use, to prepare the vessel and achieve a very nice outcome. This was a female lady that came to my hospital with a long occlusion of the FEMPOP segment. What we did, it was evaluated by IROS as a grade 4, that means 360 degrees calcification. So we use a special balloon, the Enforcer by Cook. And then the treatment was done, with several dilatation. And finally, we implant a silver PTX. This just to stress the concept that also for drug-eluting stent, vessel preparation seems to be mandatory or very important. And you see here the final outcome with a nice deployment of the stent and still, after 6 years, a patent vessel with a good ABI index. What about instant restenosis? We saw that, from the live case that is always a big challenge because it is sometimes also, a lot of metallic stuff within the vessel. Look at this guy, very similar to the case. This came to our hospital after 5 months after an endo procedure with a full metal jacket with a bare metal stent from the POP segment. This was down to the P3 segment up to the origin of the SFA. What we did was the angels. You see just a few collaterals with not a bad number of vessels below the knee. So we went in, with the Phoenix device, 2.2 millimeters, and after that we complete the procedure with a darker balloon, 5 millimeters in diameter, and this was the final outcome. You can see here we achieve a nice luminal gain with an improvement of the flow distally in below the knee region. And then 5 years follow-up, a little bit of residual material or intimate perplasia within the stent, but nothing important to modify the blood flow. There are some studies supporting the use of atherectomy plus DCB. There's an interesting paper because they combine directional atherectomy plus DCB versus standard angioplasty. And if you analyze the data, you see here the combination with the darker balloon is much better in terms of primary patency, 85% versus 73%, and also in terms of freedom from TLR. So in conclusion, we can affirm that vessel prep is now a must mandatory, not only before drug balloons, but also after drug-eluting stent. We know that there is a very important role regarding the plaque morphology. There is a lot of studies going on to evaluate the relation between the plaque morphology and the more appropriate device because fortunately we have a lot of devices available and selection should be done also according to what is more familiar in your practice but also in terms of reimbursement. Remember, atherectomy is the only way to debulk the lesion. All the other are they can modify the plaque, but they keep the material inside the vessel. Thank you for your attention.